Hi everyone, this is Kelly Lewis and this is my video discussion board post on the pain management teaching from the simulation video that we viewed with the new postpartum mom and Nurse Nancy. In the video, Nurse Nancy is taking care of this new mom. We don't have any information on the type of delivery or lacerations or episiotomies that were present. Um, so as I go through the teaching techniques in this video, I'm going to kind of touch on different options for each delivery and including um, medication and alternate routes as well. The first and most important thing is to include the patient in developing her education and doing a thorough assessment of her needs, understanding where her pain is coming from. Some causes of pain in a new postpartum mom are the involution of the uterus or the shrinking of the uterus. We are talking about an organ that was up to your diaphragm and now is involuting to usually your umbilicus or your belly button after delivery and will continue to shrink back down to normal size, which is about the size of your fist. This is accompanied usually by a lot of cramping, and it can be, just as bad as contraction pain for some patients. They really describe it as contraction-like pain. The best method for preventing this pain or for lessening it is Motrin 800 milligrams every 8 hours. We do this around the clock at our hospital. We don't wait until they need it. We keep that anti-inflammatory medication going, and that really seems to help with pain control. We also use Percocet 2 tablets as needed. And those patients, regardless of the type of delivery, go home with the same medication as a prescription. So other causes of pain would be breastfeeding. So if our mom was breastfeeding, her breast could be tender and sore. And sorry, we have a new kitten. She hasn't really learned the rules yet. Her breast would be tender and sore. Her nipples could be cracked, so her pain could be coming from this. And for those for pain in that area, we could use lanolin cream. We could talk about proper latch. We would get lactation in to make sure that she is nursing frequently and that the latch is correct. We also would talk about breast engorgement. Maybe she's already starting to feel a little bit engorged. Talking about moist heat and showers to her breasts, as well as keeping the Motrin going every 8 hours. Those things will help with this type of pain. And educating her on the fact that if she hasn't experienced breast engorgement and she is not nursing, that when she goes home that this could happen to her. And let her know about the moist heat, and I would discuss Motrin, keeping the Motrin in her system and the moist heat like a shower, doing those things to help once that pain starts. Letting her know that this is coming so that she doesn't maybe resort immediately to taking medication, and letting her know that this is normal and this is expected. That could also help decrease her fear. Sometimes when we're afraid of what we're experiencing, our perception of it could be a little bit different. When we know it's coming and we expect it, we perceive the pain that we feel a little bit differently. It's kind of like I explain, experienced moms. We know what our contractions feel like, and our perception of it is different than when we're a first-time mommy. Other things that can happen for a new mom are vaginal or perineal lacerations during delivery. A first degree is inclusive of the skin and will cause minimal pain and will heal very quickly. A second degree includes muscle tissue, and that may require some Motrin and Percocet. That pain is a little bit more intense. And a third degree or fourth degree are obviously going to be a lot more painful, and they go into the rectum, so that the patient also needs to be aware of that. She also needs to be given stool softener. She needs to be told that her first bowel movement is going to be uncomfortable. So to include her in all of this in pain management teaching is very important. It's also important to know if she had a midline episiotomy or medial lateral, because each one will cause significant pain as well. Those are for vaginal delivery. Now, if she had a C-section, then she could have the risk of having incisional pain. And methods for that would be ambulating. Ambulating is the number one alternate method that I talk to my patients about. Motrin every 8 hours and Percocet for the breakthrough pain. And other things are having a heating pad to your back and keeping the rest of you comfortable, because your back is going to get tight because you have been sitting in the bed for a little bit longer with a C-section than you did for a vaginal delivery. So, decreasing pain elsewhere will also be helpful. And, really in the teaching, talking to the patient about her history of drug abuse. Did her provider know? Is the provider aware that we're going to have a harder time controlling her pain? If her pain isn't controlled, could we talk to the provider about considering another night? Do we really need to send a homeless patient for discharge when we're not getting adequate pain control? And if she is homeless, talking to her about how she plans on affording her medications. Does she have access to a pharmacy? Is there somebody that can help her? Introducing her to the Mary V. Foundation Clinic and letting her know that this option is available to her. She would have to qualify, but a case manager could be called, and the Mary V. Foundation Clinic provides free medications to their patients, and so that this is something that we could refer her to as well. And we may, include her on the conversation. It will be harder to control your pain, and what works for you? That's always my first question. How long has it been since you were addicted to drugs and you abused prescription drugs? How long has that been? Are you afraid that if we send you home with this prescription, are you afraid of relapse? What is your plan if you feel like you are relapsing? Including her, respecting her, giving her that integrity and that honesty to really be a part of her plan of care. Talking to the doctor also, going backwards, sorry, about the amount of refills. A patient who has a history might not need 3 refills of Percocet. Maybe we can give her a 1 to 2 week supply and have her follow up in the office at that point to establish if she needs more, and if she's still having significant pain, making sure that that the pain control is adequate for her. There are a lot of alternative pain methods for the different types of pain that I discussed: ice packs, tucks, dermaplast spray, heating pads, breathing techniques, and relaxation. Obviously, the breathing techniques are affordable because they're free, and that just would take a little bit of time to talk to her about. But the other alternatives may cost money, and referring her to the Foundation Clinic again would also help with getting her some of those products. Maybe we could send her home with a week's worth of supplies. If we've got it, we could charge it in the car and give it to her to take home. So those are some options for pain control education. But the biggest thing for me is including her in the plan of care and asking her what we can do. Where is the pain? How can we help you? And how do you feel about the help that I'm giving you? Does this feel adequate to you? So, thank you very much, and I hope you guys all are having a great weekend.